Welcome to the 2021 JA Conference, and thank you for joining us. A few housekeeping tips before we begin. This session is being recorded. All attendees are muted, but please submit your questions through the Q&A. We'll get as many answered as we can. And hello, my name is Carrie Ferrero, and also helping me with this is Jennifer Burke. We're both JA moms, and we'll be your session host for today's session. Our moderator today is Robin Bree, who is the Director of Patient Education for the Arthritis Foundation. Welcome, Robin.
Hi, Carrie. Hi, Jennifer. Thanks for the introduction. It is my pleasure to introduce our speaker today, Dr. Randy Cron. Dr. Cron is an MD, PhD, and the Director of the Division of Pediatric Rheumatology at Children's of Alabama, University of Alabama at Birmingham. Dr. Cron received his MD from UCLA and completed his pediatric residency at Stanford and pediatric rheumatology fellowship at the University of Washington. Dr. Cron also has a PhD in immunology, from the University of Chicago. His clinical and translational research interests include childhood arthritis-related macrophage activation syndrome and TMJ arthritis, for both of which he is known worldwide. Dr. Cron serves as the Arthritis Foundation Alabama Chapter and Endowed Chair. And I just want to thank you all for joining us this afternoon. As Carrie mentioned before, if you have any questions, please feel free to direct them at the bottom of the screen. It's on the Q&A function, and we'll have about 15 minutes at the end of this session to try to answer as many as we can. With that, I'll hand it off to Dr. Cron, and thanks again for joining us today.
Well, thank you all for the invite, and thanks for joining us to talk about treating juvenile arthritis or managing juvenile arthritis in this era of COVID. I think I lost the slides there, so there we go. Can we have the next slide, please? Maybe you can minimize me, just so the slides are bigger for the audience.
Yeah, Dr. Cron, I think there they are. Perfect.
All right, yeah, so we can go to the next slide. So I do have disclosures, just to be transparent. Next slide, please. So just so we're all kind of on the same page, and many of you probably already know this, but just so we're all on the same page. So the coronavirus that the world is dealing with is SARS-CoV-2. It's one of the coronaviruses that can infect humans. And the disease that it can cause is COVID-19. And those terms, SARS-CoV-2 and COVID-19, are often used interchangeably, not correctly, but, and I sometimes make the same mistake. But anyway, COVID-19 is the disease, and the SARS-CoV-2 is the particular coronavirus. And as of just a few days ago, and these numbers are probably vastly low, they're probably much lower than the actual reality, but nevertheless, there have been over 190 million individuals worldwide infected, with at least 4 million deaths. And we don't, like I said, don't really know the true numerator and denominator here, but not only is it a highly contagious virus, but it's got a significant mortality rate. So, and again, we don't know the true number, but if it's around 1 or 2%, that's like, 1 in 50 people who get this virus may die. So it's a scary virus. And more currently, you've probably heard about multiple variants, including this Delta variant, which is now basically taking over in the United States, which is at least twice as contagious as the highly contagious one before it. So we may be in for a tough fall and winter. Next slide, please. So 80% of people do not require hospitalization, but 1 in 5 may. So it is a pretty severe disease for some folk. up to 30 or 40% of people, for whatever reason, who get this virus may be completely asymptomatic or mildly symptomatic. And then on this graph here, where we have disease severity on the y-axis and time moving along the x, in the first 3 days, when the virus is really replicating, people will develop fever, cough, sometimes gastrointestinal symptoms like diarrhea. And then many patients report that they have kind of a 2-day honeymoon period where their fever goes away, they feel a little bit better. And then they may go on to have kind of a flu-like illness for a week or 2 weeks. But then there's a subset of patients that get hospitalized for an oxygen requirement around day 5 or so of symptoms. This is, they're hospitalized because they need oxygen. And some may need it more severely than others. And these are the points where we'll talk a little bit about treatment, about where we probably want to intervene at treating the inflammation that's leading to this oxygen requirement. And at any point, treating the virus if you can. We just don't have great therapy for that aspect of the disease. And then the dashed line is what we'd like to see if we have good therapies for patients who become hospitalized and sick, or they get better over time. But there are some patients who go on to develop what you may have heard in the press called a cytokine storm or cytokine storm syndrome. And this is where many of the proteins that we can actually target for children with arthritis, like TNF or tumor necrosis factor or IL-1 or IL-6, become overly elevated beyond, they're trying to dampen the virus. But it gets to the point where these cytokines get so high that it leads to multi-organ failure. Next slide, please. And so this is back in early 2020, when the virus was first being reported out of China. Many of us were, reading these reports, and to some of us, it seemed like some of the features, both the clinical features that these patients with severe illness who were hospitalized were experiencing, this was adults at the time, as well as some of the laboratory findings were suggestive of these cytokine storms that we were more familiar with for other diseases. For example, children with the systemic form of juvenile arthritis who have fevers and rash, a subset of those patients can develop what the rheumatologists call macrophage activation syndrome, which we think is a cytokine storm syndrome as well. And so there was concern early on that this is maybe what's making some of these individuals very sick. Next slide, please. In addition to that, over the last 1.5 years or so, there have been very rare reports of some individuals potentially developing autoimmune diseases. And you don't need to look at this list, but there's things on there like Guillain-Barré, for example. And at the end, we'll talk a little bit more about MIS-C, or this multi-system inflammatory syndrome in children. But for the patients who are hospitalized on the right there, who become very sick with a cytokine storm, this can affect all aspects of your body, from your central nervous system to the cells that make up your blood, to your liver, you name it, severe respiratory distress syndrome, etc. So it can be a really nasty disease for those who become very ill with this. Next slide. So cytokine storm syndrome, I like to use as an umbrella term, under which we have a variety of conditions that go by a bunch of different names, and so it gets very confusing. But if you think of the cytokine storm syndrome as kind of the coverall, under which there are these different entities that share some features but are not identical. Some are treated similarly, some are not. But you may be familiar with, particularly if your child has a systemic version of juvenile arthritis, of MAS, which stands for macrophage activation syndrome. There are various cancers, white blood cell cancers like leukemias and lymphomas, that can lead to this, as well as treatment for refractory disease. You may have heard of something called cytokine release syndrome, the CAR T-cell therapy. There's genetic forms of this that are rare, familial, and it goes by the name HLH, or hemophagocytic lymphohistiocytosis. And there's a large Venn diagram circle of infections that can trigger these cytokine storms. Most of these are infections that infect inside the cell or intracellular pathogens, primarily viruses, but not exclusively. And many of the viruses that we've been studying over time that can do this include bad strains of influenza, and perhaps even 1918, that's what was going on and potentially killing a lot of individuals worldwide back then with the influenza outbreak. But there are herpes virus family members like Epstein-Barr, which leads to mononucleosis in most people, but not necessarily a severe cytokine storm. And then in red there near the bottom, some of us, not all physician scientists, lump severe coronavirus disease under this cytokine storm umbrella. And there's some evidence for and against that, as well as this multi-system inflammatory syndrome in children, which has features of Kawasaki disease, which is another childhood disease that can develop in about 2% of children in a cytokine storm. Next slide, please. We probably learned the most about cytokine storm syndromes actually from children with systemic juvenile idiopathic arthritis, because up to 40 or 50% of these children are at risk for developing macrophage activation syndrome, one of these cytokine storms. So this is data from a study that I did with Angelo Rovelli, where we collected worldwide data on children with systemic JA who developed macrophage activation syndrome. And you can see they essentially all had fever. They had big livers and spleens as part of the inflammatory process. They had arthritis, but not as high as you would expect. So even when children get MAS, their arthritis tends to be less at the population level than the 100% during a disease flare, for example. And about a third to a half of these kids will have some degree of central nervous system involvement, which can be quite severe. Next slide, please. So we developed criteria to define macrophage activation syndrome specifically for children with the systemic form of juvenile idiopathic arthritis, because it was relatively common in that disorder. Because the criteria that were out there for other cytokine storms didn't work so well. And from this, we came up with a relatively straightforward definition, which is you had to have a fever, you had to have systemic JA, or if it was at diagnosis, suspected systemic JA. And this protein serum ferritin, which is pretty common to almost all cytokine storm syndromes, it goes up. It's a marker of inflammation in these cytokine storms. So you had to have a certain elevated level of that. And then two of the following. And again, these values, these cutoffs are actually at normal levels. So a platelet count, for example, of 170,000, which would meet the criterion, is normal, but in the setting of inflammation is abnormal, or a mildly elevated liver enzyme, for example. Next slide, please. So how do these cytokine storms develop, or why do they develop? What's the pathology that we think is occurring here? So on this graph at the bottom, on the y-axis, we have just a very generic strength of your immune response. And on the x-axis is moving left to right is time. And let's say you're a normal individual, normal host, you don't have underlying conditions, and you get an infection. Your immune system will start ramping up its immune response. So you start going up that line to try to control the virus. And then the line will flatten out there in most circumstances. And this is where you're controlling the virus, if that's the pathogen. And then your immune system is actually hardwired to shut itself down. Otherwise, we'd be one giant state of inflammation or one giant lymph node if we just let the immune system go unchecked. But what's thought to occur in cytokine storms is that your immune system is incapable of shutting itself down because it has a defect. One of the potential ways is it has a defect in the ability of your white blood cells, some of your lymphocytes, to kill infected cells. So if you have cells in your body that are infected, your immune system goes after them, targets them. So you can kind of shut down the viral life cycle in this case. But if you can't do that, what's thought to occur is these cells start interacting, but without killing. Number one, the virus keeps going, but number two, it's putting out these pro-inflammatory proteins or cytokines, many of which you may know again because of our treatments. So interleukin-1, TNF, IL-6, for example. And if you have too much of that, that's what's thought to lead to the multi-organ failure that makes these patients so sick. Next slide, please. So treatment for COVID, so severe COVID disease. A lot of people have been working pretty hard at this for quite some time, and we still got a long ways to go. But I think to many people's surprise, not necessarily some of us, but to many people's surprise, the one therapy, and it's not a home run, but it's better than anything else that's been demonstrated, and it's been shown in multiple studies now, that helps patients with the severe lung disease and cytokine storm are glucocorticoids or corticosteroids. These are things like prednisone or solumedrol or dexamethasone here in this case. And the summary data shown here. So if you look at that, anything that's kind of to the left of that 1 suggests that it's going to improve survival. And so there's convincing data that steroids will improve survival. There are important points though to make, and that is, if you don't require oxygen, steroids may actually make things worse. So early in the disease, when the virus is replicating, steroids are dampening your immune system, allowing the virus to go more uncontrolled. But later in the immune response, when it's the immune system that's causing the damage, that's when steroids are beneficial. So the more severely ill you are, the more beneficial the steroids will be. So this is just a point that you don't want to be taking steroids if you're not hospitalized and you're not requiring oxygen. So don't be taking them at home, because that potentially would make things worse. But they can save lives. It's the one drug out there that's consistently been shown to improve survival. Next slide, please. So MIS-C, so multi-system inflammatory syndrome in children. I don't think very few, if any of us, predicted this. This was kind of just a shock to many of us. And this was initially reported in Europe, places like the United Kingdom and Italy. And then when COVID hit the northeastern United States, like New York, Massachusetts, Pennsylvania, pretty hard early on during the pandemic in this country, within a month, some of these kids started showing up. We didn't really know what this was till our colleagues in Europe started reporting it as well, because they had had this experience before us. And if you look at that graph on the right there, kind of that yellow curve, is the number of coronavirus cases. These are essentially mostly adults over a time frame there. And those red bars are children with this new condition, MIS-C. And they occur about a month after the peak in whatever community you happen to be in. And so it seems that this is a post-infectious. They're following the infection. And some of these kids had completely asymptomatic infections and didn't even know they were infected, but may have had known exposures to the virus. Others had, mild disease that they got rid of, but a month later got very, very sick. And this MIS-C shares some features with this disease, Kawasaki disease, that we talked about, particularly in those children who tend to be under 5. And so that in part tailored some of the treatment approaches that we'll talk about a little bit later. But the older kids had more gastrointestinal complaints. And so the way these children typically present, particularly the older kids, is in the emergency room very sick and in a state of shock often, because they're volume depleted. They have substantial vomiting and diarrhea, and their blood vessels are leaking. So they may need support to maintain their blood pressure through things that stimulate their heart, for example. And they can get inflammation of the heart itself, particularly, again, in the older age population. So these kids come in very ill, but without the respiratory symptoms typically that you would get with the virus itself. Next slide, please. So our first year fellow, Dan Reif, has probably seen about 90 of these kids, at least in Birmingham. And he put together kind of this case series describing the differences, because in Birmingham, unlike the spike that occurred in the Northeast, it was kind of a steady flow of coronavirus infections. So the hospitals were just kind of this steady level. It would go up and down a little bit, but steady level of COVID-19. And then you can see that overlapping with the kids who would develop the post-infectious MIS-C. And so Dan compared these two populations. Next slide, please. And if we just focus on the left part of this graph, because they're virtually identical, he broke them out into all or the severe cases. But the COVID-19 patients, for the most part, very similar to what we see in adults, had underlying conditions as risk factors, and very similar risk factors to the adults. For example, obesity, chronic lung disease, cancer, autoimmune disease. We didn't see a bunch of children with juvenile arthritis. We saw some lupus patients, for example, diabetes, and a significant number of developmental delays. So having a risk factor was a big risk for having severe coronavirus disease with oxygen requirements requiring hospitalization for children as well as adults. Now, this is still much less common than in adults, but it does occur. The MIS-C children were the complete opposite of that, in that they didn't have prior diagnoses. They were previously healthy children, so not kids with autoimmune diseases, for example. There were a couple kids with asthma, but asthma is a relatively common condition. So that was pretty interesting. Next slide, please. And so one of the ways that we could distinguish these kids, because when you first meet them, you're not sure what's going on, is the kids with coronavirus disease had underlying medical conditions in their history, and they primarily present, just like the adults, with oxygen requirements and with respiratory symptoms, cough, shortness of breath. Whereas the children with MIS-C, for the most part, were previously healthy children, not entirely, but mostly, and presented with fever, but instead of lung symptoms, they had gut symptoms, vomiting and diarrhea. The younger kids had some of these features of Kawasaki disease with rash and red eyes or conjunctivitis. And because this seems to be a post-infectious process, they either knew they had the infection a month or so prior or had a known exposure in that month. Next slide. So treating these kids. So we were fortunate, none of the patients so far at our institution have died from either COVID or from MIS-C, but some have been very, very sick. The children with COVID, because by the time it was hitting us harder in Birmingham, we had learned about the benefit of steroids. A bulk of them received glucocorticoids for the respiratory disease. And the bulk also received an antiviral remdesivir, which has not been proven to improve survival, but it has been shown to shorten hospital stay. It's the only antiviral that I'm aware of that has really benefited this disease. And some of these patients, about a third, received the IL-1 blocker anakinra for a cytokine storm component that was not controlled with the steroids alone. Their mean length of stay or mean hospitalization was 2 weeks, and for the more severe ones, a month. Contrast that to the children who had MIS-C, or this post-infectious process. They almost all received intravenous immunoglobulin, or IVIG, because that's standard of care for children with Kawasaki disease, and early on this had a lot of features with that, particularly in the young. And that's known to prevent inflammation of the coronary arteries, or the arteries that supply the heart, which is a complication of Kawasaki if you don't receive that. Again, because they had a cytokine storm component, probably even more than the actual COVID-19 patients, they did receive steroids, and a few received anakinra. But their mean length of stay, despite the fact they typically came in sicker, often requiring what we call inotropes, or support for the for the cardiac function, was only 5 days, and even the more severe ones, about a week. Next slide. So this is a question I'm sure you're all asking, we're asking ourselves: are children with our autoimmune disease, and particularly juvenile arthritis, at risk for increased infections? Are they more likely to get the coronavirus? And if they do, are they more likely to have a worse outcome? We have very little data on this, but if you extrapolate from adult data, the bottom line is probably not so much. So kids with rheumatic conditions do pretty well. And so this is a study out of Turkey, and this is 345 children with juvenile idiopathic arthritis. And only 2 of those children developed COVID. Two were on TNF inhibitors, tumor necrosis factor inhibitors. One was on etanercept, also known as Enbrel, and one was on adalimumab, also known as Humira. Neither one required hospitalization, and they both recovered. So in general, we are leaving our patients on the medicines they're on to control their disease. Next slide. Similarly, this report out of Italy on children with juvenile arthritis and who had uveitis, so many children with JIA, particularly the oligoarticular younger kids who are ANA positive, develop inflammation of their eyes in the form of uveitis. None of those patients were infected. Again, small numbers here, 125 kids. only 2 of them had uncontrolled eye disease, which was kind of the rate that they had prior to the pandemic. So again, they left them on whatever medicines were treating their arthritis and or their uveitis. These are typically things like methotrexate or TNF antibodies like adalimumab or infliximab. Next slide. This is data from our Centers for Disease Control, published in the MMWR pretty recently on data from March 2020 up through April of this year. And it's in children aged 12 to 17. And the bottom line is, again, kind of like what we saw here in Birmingham, but on a much broader scale here, children that were hospitalized with COVID pneumonia had underlying chronic medical conditions, whether it's obesity, chronic lung disease, diabetes, etc. But none of these patients died. Now, this is only data from 14 states, so I'm sure there have been, unfortunately, children who may have died from coronavirus disease, but for the most part, kids, even if they're hospitalized, can recover. Next slide. So recommendations. So there've been a lot of groups, including the American College of Rheumatology and others, who have put out recommendations for what to do for patients with rheumatic diseases, for example. I just picked this one, a more recent one, the Singapore chapter for rheumatologists, and this was really for adults. And these recommendations, some parents have actually been part of some of the recommendations I've been involved in. But if you're not familiar with it, a lot of it is reviewing the literature as best you can, and how strong are individual papers that you read. You know, were they randomized trials or are they just retrospective case series, et cetera? And then doing through various processes like a Delphi process, voting on whatever recommendations you're going to make. And the bottom line from all of this is that, again, for the most part, rheumatologists, both pediatric and adult, are suggesting that the patient stay on the medicines they were already on. Now, if they're doing great and you can lower steroids, for example, you can go ahead and try that. But for the most part, controlling the disease and keeping that under control is better than just stopping meds. There are a few exceptions. Again, high-dose steroids, probably not great either for risk of doing poorly with the virus, for example, or in terms of trying to mount an immune response if your child is 12 or older and is eligible for the vaccine. So some folks will recommend, for example, if you're on methotrexate or a TNF inhibitor, that you hold that dose just the week after you get your immunization. And the good news is, if your child is on a biologic, particularly the TNF inhibitors, they capture back disease pretty quickly, even if you miss a dose. It's not to suggest that you periodically miss doses, but if you do for the vaccine, for example, and you have a small flare, then the next week things tend to go well if you go back on it. There's another drug, and I don't know if anyone in this Zoom meeting has a child on rituximab. This is an antibody that we use in lupus quite a bit, for example, but is occasionally used in arthritis. And this removes one of your lymphocytes, your B cells. And there, you're going to have a very hard time developing an antibody response. You may develop what we call a T cell response, but you may have a really hard time developing an antibody response if those cells are removed, because those cells give rise to these cells called plasma cells, which make antibodies. So they do suggest, if you need rituximab for your treatment of your rheumatic disease, that you might want to time it, if possible, to give it after you've mounted a response to your vaccine. But for the most part, again, the bottom line is most recommendations suggest that patients with rheumatic diseases stay on their current therapy. Next slide. The American Academy of Pediatrics, and you can go to their website, has some very constantly updated recent recommendations. And I think this is mostly in anticipation of the school year starting up very soon in many parts of this country. And their recommendations, and states have a lot of different ways of approaching this, is that for children 2 years and older, including all the staff at the schools, if you're attending in person, you should be wearing a mask. And so one of the silver linings from this pandemic have been the vaccines and their high efficacy and their low side effects. But the other thing we've learned, and we didn't know this early on, is that masking works, and it doesn't have to be an N95. I mean, those are definitely some of the best masks out there, but even cloth masks or multiple cloth masks are very good. They're not perfect, but they really cut down on transmission and infectivity. So masking works, and because at this point in time, although maybe in a month or two we'll have data from some of these vaccine trials that the FDA may give emergency authorization use for, hopefully we can get our 2 to 12-year-olds immunized, 6 months to 12-year-olds immunized sooner than later. But currently 12 through 18 can all get the Pfizer vaccine. Recently, the Moderna, which is also an mRNA vaccine like the Pfizer, was approved in Europe and may be approved at some point in the United States as well. But the Pfizer vaccine is 100% effective at keeping teenagers out of the hospital and 100% at preventing death. So if your child is in that age range, they should definitely get it. But either way, for everyone 2 or older, the AAP or the American Academy of Pediatrics is recommending masking. Next slide, please. And to date, and these are somewhat sobering statistics, as of really just about a week and a half ago, July 14th, 9 million children under age 18 have received at least 1 dose, but only 38%, or about 7 million children of the 16 to 17 age group, have received both, so they're fully protected. And only a quarter of those 12 to 15, these are all eligible to get it, have received 2 doses of the virus. And the Arthritis Foundation on their website has expert opinion, again, but good advice on answering some of these questions, like, are COVID vaccines safe for children with juvenile arthritis? Which vaccines are approved? And at this point in time, it's really just the Pfizer vaccine, but that may change. Hopefully it will. And what are some of the severe side effects that can develop? And as we talked about before, should we stop taking the immunosuppressive medicine? Next slide, please. And so the CDC, or Centers for Disease Control, has thoughts on this as well. So again, the silver lining is we got really lucky with the vaccines, all the vaccines, not just the mRNA vaccines, that at least have been studied in the United States, and that they're incredibly safe and effective at preventing severe coronavirus disease, particularly death. And they do reduce the risk of spread throughout. So concerning to me, and I think to a lot of us, is that until we get our population highly vaccinated, this is not going away, and this is going to affect all aspects of our life. So worldwide is a huge issue, and I'm afraid we're going to be dealing with this maybe for a few more years at best. So vaccines are incredibly effective against this virus. Even the variants, the mRNA vaccines are good against the variants, but that may change. So the longer these viruses exist in the human population and continue to divide and replicate, we're at risk for developing even more severe forms or variants. Let's see. So if you get a vaccine, it's like a lot of other kind of vaccines. You get it typically in your arm. It's common to have pain, redness, swelling at that site that lasts for a few days. Some people, particularly with the second dose for the mRNA vaccines, but it can occur with the first, but mostly with the second dose, will get more kind of systemic or overall body feelings that are very much like having the flu. But these typically, again, resolve within 2 to 3 days. So that's the relative price to pay versus the risk of being hospitalized with severe coronavirus disease. And you're not fully really vaccinated until about 2 weeks after your second dose. So all the precautions that you should be taking, even if you're vaccinated, but certainly prior to 2 weeks after your second dose, you should be taking. Next slide. So there is this one entity that you also may have heard about, because it's hit the news, of chest pain in young men. So men kind of age 18 to 30 is the age range, but it likely will occur in teenagers as well. And I know it has anecdotally from colleagues and a few patients here in Birmingham. And it's inflammation of the heart that occurs after the vaccination. It's exceedingly rare. I am unaware of any patient who has died from this, and most of it kind of self-resolves. Some people have received steroids, but most of it kind of self-resolves within a couple days. And again, you're weighing the relative benefits and side effects. So the data here suggests that for men under 30, you'll prevent 11,000 cases per million vaccines and potentially have about 40 to 50 of these side effects per million vaccines. So not very often, and prevent at the same time 6 deaths in the process. So weighing all things, this is an outside chance, again, exceedingly rare, but the benefit far outweighs this potential risk. Next slide. So another silver lining, just to switch guns a little bit here, but is definitely dealing with treating juvenile arthritis during the pandemic, has been telemedicine. And I personally, I've been fighting it for a while because I just think as a rheumatologist, particularly a pediatric rheumatologist, it's very hard to know over the phone or over Zoom or whatever how a child is doing if we can't examine their joints, for example, at a minimum, let alone look at their skin or all these other things that we do. But now I'm a huge fan, I think like many of us, of this type of medicine. And there are a lot of reasons for this. One is in places like Birmingham, where we're really the only place in the state, for example, we have families who come maybe 4 or 5 hours to see us. That's not fun. So our policy has kind of been, if you are doing well with your arthritis, for example, in remission, your disease is quiet, that we alternate visits if the family wants to, right? So they have the option of seeing us in person every single time, but if they want to, then we can alternate our visits so that we're at least seeing, and on average, our visits when children are doing well are every 4 to 5 months. So a couple times a year, we may see them in person, or 1 time a year, if just depending on how things fall. But so telemedicine has a lot of advantages. It doesn't, all that time wasted traveling, gas money, which is not trivial for some of our families. There's a lot of potential good things, and it's not going to be me who does this, but I think that it might be worth educating families on how to recognize arthritis, how to do a basic joint exam, not just for telemedicine, but just anytime in between doctor visits, right? So that may be something that comes along with this as well. There are downsides, not everyone has great internet access. Sometimes technically we get challenges with the internet or just the platforms we're using. And clearly you can't do things that you can do in person in terms of the actual exam. You can replicate some of the joint exam, and all of us have various approaches to what we ask our patients to do over Zoom, for example, but it's just not the same as being in person. But hopefully it's here to stay. Next slide. So that was a lot of stuff, but here's my major summary take-home points, is that some of the most basic stuff that you can do is really effective, and we all can do it. Masking, social distancing, hand hygiene prevents a lot of this spread. So we should take advantage of that. And the vaccines are incredibly beneficial and safe with large numbers of data. We have, hundreds of millions of people now who have received vaccines. So we have a lot of data. Like outside of a pandemic, you would never get that kind of data. So every child 12 years or older should be vaccinated, including children with juvenile arthritis. And hopefully sooner than later, we'll get emergency authorization from the FDA if the data looks to be good in children kind of 6 months to 12 years. And I think some of the preliminary data suggests that it is. For the most part, the therapies your child is already on, they should stay on, although you may hold a dose after an immunization, for example. But prior to doing any of that, I would just discuss it with your own pediatric rheumatologist in detail, and you can come up with a plan for your child and between you and the doc and the family. And then, like the last point I made, telemedicine seems to be here to stay, and I hope it is. I hope the third-party payers can continue to pay for it and not on a month-by-month basis tell us whether they're going to continue to cover it or not, because I think it is a valuable part of medicine, and it is going to be the future even beyond the pandemic. And I'm happy to answer questions. I'll let people. Robin's kind of frozen, so maybe while she's frozen, there are some that are coming in through the chat that I can try to address. So one of them is about a booster. If you've already had 2 doses.
Hi, Dr. Crum. Thanks so much for that. Incredibly informative. To remind everybody to put them in the Q&As. I would like to say, oh
no. So the booster, at this point, no one knows. The one thing we do know is that the vaccines tend to provide longer protection, at least in terms of antibody titers that we can measure, than getting infected itself. So even if you have been infected, you should also be immunized. And it's a good question about whether boosters are going to be required. My guess is yes. I personally would take one now because it's been over 6 months since I've had my mRNA vaccines. And they can also, the beauty of the mRNA technology, at least that particular one, is it's relatively easy for the companies to change sequence to deal with variants. But fortunately, at this point, the mRNA vaccines in particular are protective against the current variants, including the Delta variants.
I believe I'm not frozen anymore. Sorry about that. I just wanted to tell everybody that we do have a COVID vaccines and variants seminar coming right up at 3 o'clock. So you will, all these questions that you guys are asking about the vaccine will be addressed then. We will take a few questions about the vaccine, but we did have some prior. Dr. Cron, I'd like to get your input about the Delta variant and the risk. Is there any indication that children with JA or just children in general are more at risk for complications due to this strain? And if so, what are some measures that we can take to protect our children, especially going back to school in the fall?
Not that I'm aware of. The Delta variant, and there are a couple of versions of it, but the primary one has a mutation in this protein called the spike protein. And so it probably makes it more contagious, like more infectious. Mm-hmm. But that shouldn't make a difference, whether you have JA or not. But the second part of that question is kind of the stuff I was really trying to drive home, is that basic things, masking, social distancing, avoiding large crowds, particularly indoors, hand washing, those are awesome and they work. But more importantly, getting vaccinated if your child is in that age range. And I know everyone under 12 is not, right? And so you're going to have to rely on the basic things first. The other thing, and I think I forgot to mention this, is that if you really want to protect your child, you yourselves, everyone in the family who's eligible should be immunized, as well as other close contacts that your child may have. So vaccinations, thank goodness. I mean, we'd be in big trouble without them, but we still got a long road ahead of us.
What about recommendations for the upcoming school year? Would you recommend, because I know the CDC had a recent push towards going back to school. For parents who are concerned about sending their children back to school, would you maybe advocate for them putting in their 504 plans or their educational rights plans to be remote or in person? Or I know that the American Academy of Pediatrics petition for masks, but are there any sort of accommodations that you would absolutely recommend that parents ask for this year?
I mean, it's kind of a hot mess because for the most part, it's being left up to, at least in Alabama, for example, it's being left up to individual school districts. And so I would definitely talk, with the folks in your school system, from the superintendent on down, as to what they're going to allow, what they aren't going to allow. During the height of the pandemic, both of my children did virtual school, and they were okay with that. But there is a definite downside to not being around other kids and not being in the actual learning environment. And so there is huge benefit of actually attending in person. And if you can prevent infections by basic mechanisms, and for the older kids, certainly by immunizations, than do it. But it may just come down to an individual patient. But I think for the most part, including most of my patients in just my kind of surveying them in clinic or by telehealth, is they are planning to go to school. Not all of them, and some of them were homeschooled prior to the pandemic, so that's kind of a moot point for them. But I would say for the most part, if your family is immunized, the people who can be, even if your child is young enough that they can't be immunized, if you're doing the basic stuff, particularly masking, social distancing, hand washing, avoiding probably indoor restaurants, stuff like that, it's probably okay.
That brings me to my next question. For families with children who are too young to be vaccinated, are there certain precautions that these families should take if they have been vaccinated? Do you recommend them still, like you said, avoiding indoor restaurants, wearing masks at all times until their children are able to do so?
Yeah, I mean, it's basically the same answer I just gave you.
Right. Yeah. What about, we have a question from Mary. She says her child is in the middle of a bad flare. Should she proceed with the vaccine with so much active flare or wait it out? Is there a recommendation for that?
Yeah, it's all just guesswork. And so I would talk with your primary care pediatric, I'm not your primary pediatric rheumatologist, as opposed to just taking advice from me. But I would try to get the disease under control if you can first. It also is going to depend whether your child has systemic arthritis versus the other forms, because systemic, that would probably be definite advice. That may not necessarily be advice for the other forms, even if your arthritis is flaring.
Okay. What about symptoms of COVID? Are we finding that symptoms of COVID are different in children than in adults?
Not really. So if you, in a sense that for the most part, children don't get as sick as adults. So there's a higher percentage of children are asymptomatic or have no or minimal symptoms. So that's good. But of those who get sick, and we have a biased opinion, those of us at university settings, which is the vast majority of us as pediatric rheumatologists in this country, in seeing these kids, the sick kids that are like the adults. They get the same kind of nasty respiratory symptoms. But the Miss-C is a unique thing that we don't see very often in adults. They call it Miss-A, A for adult. But that's not all that common. And the Miss-C is not that all common either, but we see, like I said, we've seen 90 plus kids here just in Birmingham alone. And so that is different. I mean, and they're presenting in shock with mostly gastrointestinal symptoms and fever. And the younger kids with features of Kawasaki disease like rash and red eyes, for example.
I think we have time for one or two more questions. And I'm excuse me if you answered this while I was paused. Is there much of a difference between the Pfizer and Moderna vaccine? Is there one that you would recommend over one or the other?
Well, at this point in time, the only one that's available for anyone under 18 is Pfizer, but that may change. Like Moderna is now accepted in Europe, so that may happen here as well. To the best of my knowledge, they're virtually identical in terms of their benefits and potential side effects. They both work very well.
And I'd like to just remind everybody again that these vaccine questions and more will be addressed in our general session at 3:15. And we are also having a school solutions lecture tomorrow. So I encourage you all to check that out. Last question, are there any words of encouragement you would give to family members that are hesitant to receive the vaccine?
Nothing in life is free, right? So we're all in life in general, you're weighing risks and benefits all the time. Should I drive my car to work? There's a risk I could be in a car wreck, right? But you do things based on risk benefit. And in medicine, that's really the case. That's all that's a lot of what we do in medicine is risk benefit analysis. And there are rare side effects. They happen, right? But on an individual basis, they are rare. And so, like I said, because this is a pandemic, we have immense amounts of data now. And the data is compelling that vaccines work and there are only rare instances of side effects. Yeah, it's, you know, it's a tough question. I would definitely talk to your pediatric rheumatologist. I talk, it's part of my visit every time now is talking about vaccines. And, you know, vaccines can be scary for sure and can be not so effective like our annual flu shot, although it's still recommended, but these are incredibly effective. So you can't promise that you won't have a side effect from it. But again, even if you got kind of 2 to 3 days of feeling gunky like you have the flu, that's a relatively small price to pay for preventing a hospitalization.
I couldn't agree more. Dr. Khan, thank you so much for your time today. I know that we've all learned a lot and our families are very thankful for your input and your expertise. I'm going to hand it back over to Jennifer and Carrie. And I just want to thank everybody for attending, and please join our general session about COVID vaccines, variants, and JA at 3:10. So take care, everyone.
Stay well.
We'd like to thank Dr. Kron for being with us today at the JA virtual conference and for sharing your expertise with us. It truly means so much to us. We'd also like to thank Robin for moderating, for Carrie for also helping host, and to each and every one of you attendees. We appreciate you joining us today. Please take a moment and to provide feedback for our session by completing the conference survey that is in the app. This is going to help us guide us with programming in the future. So be sure to come back for our general session on COVID variants, vaccines, and JA family. We are going to start that promptly at 3:10 p.m. That's Eastern time. You can find the Zoom link for this general session in the conference app. Don't forget to check out all the kids and teen sessions that are in the app. You can watch them throughout the day. A lot of them are recorded, so you can watch them anytime over this weekend. And also be sure to check the conference app for the Arthritis Foundation resources. And I would encourage each and every one of you to take part in JA Insights today. That can be accessed through the link in the app. So again, you have a quick stretch break, get ready to enjoy our next general session. And again, that starts at 3:10 p.m. and that is Eastern time. Thank you so much. And I hope everyone enjoys their day.